Hello there, and welcome back. Seems like things are getting a little crazy around the world right now, but I'm here to tell you that we're just keeping it business as usual here at the Price of Pain podcast. Tried to do something unique with this episode and bring in a team physician for University of Florida who works with a number of the teams, and I met on a trip with Florida volleyball in the postseason last fall and immediately thought that she would be a great guest for the show. This is Dr. Sarah Chrabaszcz, and she is trained in emergency medicine and actually still works in emergency medicine while completing her fellowship in sports medicine here at the University of Florida. She has a unique perspective in the respect that she is, like I said, a practicing physician in two different fields. And I was hoping to get a little bit more, honestly, maybe some stories and whatnot, but when you add HIPAA, which protects people's health information and personal information, and how tightly the athletic organizations protect the privacy of their athletes, I wasn't as able to get into some of those stories as much as I would like to, but she still provided a great perspective. And I think it's a welcome change from some of the research-oriented episodes that we've had. I learned a number of new things, but one, I'm going to give you a pop quiz and see if you can answer this by the end of the episode. Of all of the sports that Dr. Chrabaszcz works, can you guess which one has the most injuries, that has her working the most when she attends their competitive events? Aside from that, we're going to get on with the episode. So welcome back for another round. Let's get to it.
Welcome to The Price of Pain, brought to you by the Pain Research and Intervention Center of Excellence at the University of Florida. Let's join host Dr. Joshua Crow in conversations with scientists, healthcare providers, and industry professionals as we delve into the highly subjective experience of pain and the ongoing effort to reveal its influence on our everyday lives.
Do you work with the athletic trainers in preparation, or are you really, I guess my main question is, are you preventative, on game day and in practices and whatnot, or are you really more reactionary to, anything bad that might happen?
I would say it's a combination of both. I think the athletic training staff is really great because they know the players a lot better than any physician is going to know the team. So they're all day with the players, every single practice. So they already know, hey, this might come up during the game, just to be aware, or hey, that he's been dealing with this all week. So we are kind of on the lookout with that. But I would say it's a combination of both.
That's got to be a lot of charts to manage, if they're ongoing files for all of these athletes. Because how many sports do you work?
I work all the sports here. Yeah, so it's a lot.
How many? All of them.
Yes, all of them. But the Epic EMR is great, so you can look up and see your past notes and everything.
That's cool. Do you? Okay, I'm not going to ask favorites per se, but are there sports that you work that you get to apply your trade more than others? Yes,
I would say so far cross country and football definitely. Just because my background is emergency medicine, that's what I did my residency in before I did a sports medicine fellowship. And with those sports, there have been a lot more kind of acute injuries, acute illnesses, management, which I love. It's just like being in the trauma bay, resuscitation bays in the ED, but with a lot less resources.
Okay, you mentioned that. We met on a flight to Louisville.
Yes.
For the NCAA Women's Volleyball Championship Tournament. And I had asked a little bit about that. As a matter of fact, that's when I was like, oh, you'd be great for the podcast. But you said back then that you mentioned cross country, and in the time since, I've forgotten that. I'm going to tell you right now, if I were to think of any sport that's like, oh yeah, that's like the trauma bay, cross country would not be it. So what kind of things do you? Where are the parallels there? What am I not getting?
Yeah, a lot of people actually say that. They're like, oh, are the runners, stepping in holes and twisting their ankles, which is not the case at all. They're fantastic athletes, and it's almost none musculoskeletal injuries, but it's, acute heat stroke, heat illness, acute asthma exacerbations, dehydration, those sort of things where you're really using kind of your emergency medicine background, and kind of it's more of a medical resuscitation.
Okay. And on average, so the cross-country events, actually it's a little bit embarrassing. I get very much, not only in academia, when we're researching, get to this point, we tend to kind of get into a groove and have a blind spot that covers pretty much everything else in the world. But with athletics as well, I have to admit, I get so focused on volleyball that I lose sight of a lot of other things. So we need to lay a little bit of groundwork. Cross-country events, is it all the same distance? And for anybody that's listening in that is a cross-country runner or a former cross-country runner, please save the hate mail. I'm sorry, this is a learning moment for me.
Actually, that's a good question because they're different.
Okay.
So I covered the pre-national meet in Tallahassee and then also the NCAA national cross-country meet in Tallahassee. And for the nationals meet, it's a longer distance than the pre-nationals, which can, if runners aren't, training for that longer distance, they're already pushing themselves to the max to run their usual distance. And now you're adding, I think it's 2 more kilometers, approximately.
Okay.
So that can really add some excitement.
What are the distances specifically? It's only a 2-kilometer difference?
So don't quote me on this.
So put you in the same spot that I was just in.
Yeah, because it was a while ago. But I want to say that for men, it's about 8K, and then nationals, it's 10K.
Okay.
Something kind of like that. But when you're kind of, already pushing yourself over the limit on race day, and then you got to go longer just for the nationals meet, that was really exciting.
So I've played volleyball. I was a martial artist. Played hockey. I'm not a runner. I don't do endurance stuff at all. And so the concept of, I guess, knowing yourself as an athlete to establish a pace for that duration of time and that distance is totally foreign to me. But I would imagine that kind of repetitive movement and that continued cardiovascular stress and cardiorespiratory stress and, especially, in this part of the country, that's where a lot of those things that you're talking about with heat stroke and all that come in, is that they're finding a pace that the fastest pace that they can maintain, I would guess, for that distance. And that seems to be a lot of physiological stress.
Yes, and I mean all of these athletes who I saw were elite athletes in their sport. Clearly, I'm also not an elite runner either. So all these people are amazing. But even just taking say a nationals meet, and you're taking people from different parts of the country. So some teams train at a higher altitude, so they're great. But then you come in the Florida heat and the humidity, it's a whole different ball game.
Yeah, it's like breathing underwater, right?
Yes. Yeah. So I think there's kind of, pros and cons to where you train, definitely.
So when you're, let's stick with cross country for just a moment, since it's so foreign to me at least. I'm hoping that it'll be interesting to somebody else as well. When you have to treat these things, since we are a pain podcast, I do want to circle back to this from time to time. What are some of the signs and symptoms that you see, and are any of them pain related? Do when these runners are experiencing heat stroke or any kind of climate or environmental effects, is it painful? Are they in pain? Do you use that to gauge the severity of their condition? Or?
So I would say that, going back to my emergency medicine background, if somebody is able to tell me I'm in pain or speak to me in full sentences, that's a positive sign already. So for somebody, having severe heat illness or even the heat stroke where they could be completely unresponsive or, not able to talk to you or completely altered, that's, if they're able to tell me something hurts, then that's a good sign.
That's a good sign, yeah. That at least tells you where along the spectrum they're not.
Yes.
Right? Okay.
Yeah.
All right. So in addition to cross country, football.
Yes.
I feel like that's got to keep you busy.
That was a huge part of my fall during fellowship, but I loved every single moment of it. And we covered the practices as well. So my co-fellow and I would split up practices, but then we would both cover all the games. So that, you really get to develop a relationship with that team more so than other sports, which I really liked.
That's cool. And I mean, that's a lot of, just real quick recap. How many people on, say, men's and women's cross country, how many people are we talking about for the rosters?
Well, for the meets that I covered, because they weren't, the full team.
It's not the full team.
So they were, about 35 teams for women.
Oh, and so you're not just working with the Florida teams. You're working for everybody.
For everybody.
I see.
Yeah, so it's kind of covering, a couple hundred runners.
Okay, so that's about the same as working with the football team. Then that's what I was getting at.
Yes.
Is sheer numbers wise.
Yes.
It's a lot of people to establish a rapport with and all that. So I guess that makes sense why the team specific athletic trainers have a little bit more
Yes.
comprehensive knowledge of the athletes that they're working with.
Yeah, and we really do rely on them, especially in, emergencies or acute situations. You want that person who knows, okay, what's going on, what medical problems do they have, just to kind of rattle it off.
That's all right. Well, okay. So and I should put out a disclaimer. I'm pretty aware that the athletes' privacy is a major priority for not just for University of Florida, but pretty much anywhere. Then of course you have HIPAA, as a physician, that all that protected health information. So I may ask questions over the course of this conversation. I'm not trying to get the juicy details on who's on the injury reserve or anything like that, but I think that you probably have an insight into some of the behind the scenes stuff that not only that you have to do, but that are indications of how far along science and medicine have come, and in the application of keeping these really high functioning humans at that high functioning level. So if I do ask anything that you have to tap dance around, it's okay to just blatantly say, well, I better not answer that. That's totally fine to say. Now, having said that,
Yes.
when it comes to football, do you have to do a lot of work? We see most people don't go to football practices, for Division I football. So we see what competition looks like, but in practice, do you get a fair amount of work in practice as well when you're working with the team? I mean, and if so, what's the range of things that you might have to deal with there?
So our role pretty much during practice is we're on the sidelines. So for any kind of sideline emergency, such as similar to a football game. And then after practice, we can see any type of complaint in the training room. So more of a routine complaint, or, something happened during practice, or, is this an illness going on? So it's kind of a wide range in the training room, but on the sidelines, it's more of the acute injuries.
So you do, and for the training room, that's where the athletic trainers are. It's where they can receive, rehabilitative treatment, et cetera. Do you spend a fair amount of time in there with the athletic trainers, or is it more interfacing and you work with acute stuff and then they move on and kind of do the longitudinal work? Or
So the training room is set up where there is an exam room, a physician's exam room. It looks similar to a clinic room, and that's pretty much where we'll hang out. And then anybody, it's kind of an open door policy. Whoever wants to be seen can, is more than welcome to come see us. And the trainers already have an insight of, who needs to be seen and things like that. So it's separate enough that the trainers can still do their treatments and things like that.
What about other sports that are non-contact sports like gymnastics or whatnot? Whenever I watch gymnastics, it always seems like, wow, like these, particularly, women's gymnastics, because that's the team that we have here. But whenever I watch women's gymnastics, first of all, like my knees and back and shoulders ache just watching. I'm thinking, wow, that really looks like they're beating themselves up. Have you spent some time working with them as well?
Yes. Yeah, I have covered a gymnastics meet, and they are, again, amazing athletes just to watch. They're so fun to watch. They're great.
How much would you say they're practicing? And again, this is a broad question, but how often do you say that sports like that are even the contact sports, how often do you feel that the athletes are working either through training or playing with some degree of pain, even if it's just soreness? Is that something that athletes kind of regularly have to deal with at that level? Or is...
I would say that being an SEC school, these are all elite athletes. So kind of working through, from training camps and soreness, they're really put an emphasis on, good hydration, good nutrition, good treatments afterwards. Do they need, massages, ice baths, all those things to kind of get them through the next practice. So it's pretty well thought out through, the whole medical and training staff and athletic staff. There's a lot of people that go into it because if you, want to perform at 100% every single day and every single practice, you need to kind of be taking care of that recovery too.
Yeah, I was just going to say, It seems like the recovery is just as important, if not
huge.
More so than the training itself. Yeah. Do you think that's kind of what separates some of the more elite schools with from the rest is that the resources that can be devoted to that, but then also the focus and the ability to work the athletes through recovery?
I think that's definitely part of it. And I think even, people just looking at, fans looking at, SEC sports and things like that, they can see kind of the resources that are dedicated to all these different pieces, and, the dietitians and nutrition and all these small things really add up and can make a difference.
Yeah. there's a lot of research in my interest in aging research, but with some dietary effects of chronic inflammation and how that chronic inflammation can set a threshold for any types of acute or acute on chronic pain that might come about later. But if you think of it as a dial where 10 is excruciating pain and 0 is no pain, with a lot of people based on their diet, it seems like that they're kind of set at maybe a 3 or a 4 already, or a 2 or a 3 at least, just because of the inflammation that some of the things that they're eating. So, I think that's something that a lot of people don't realize with elite collegiate level athletes, even how, I don't want to say tightly controlled, but how much monitoring goes on in advising diet and trying to keep the athletes in that type of game ready condition.
I think that is one of the newer topics that are coming about, that people are realizing how big of a role nutrition and diet can play, even just in the everyday person, like you said, with pain and kind of that sort of response. I think in the next 20 years, we're going to learn a lot more.
Yeah. One of my colleagues is actually looking at relationships between body composition and pain, and looking at a number of factors. But one of the conversations that I'm eager to have with her is, we know to an extent that body fat can be pro-inflammatory. So the more body fat you have, the more likely you're to be in a chronic inflammatory state. And so, I'd be interested to see how athletes can be continually fueled and have the necessary levels of fat. Because, not all fat's bad, of course. It's a necessary, not only dietary substrate, but a necessary tissue in the body. But to find that sweet spot, I'll be interested to see how much diet and those effects of diet on younger, healthier, or even elite performing populations will influence and inform what we do for healthy aging. Because that, like I said, that's more of an interest of mine as well.
Yeah, I think definitely having that emphasis on preventative healthcare, preventative healthy aging, as you call it, I think that'll be a huge difference.
So let's talk a little bit about you
Okay.
now that we're into this. You mentioned just a moment ago that your background and your training is in emergency medicine.
Yes.
But right now, how far into your fellowship are you?
I'm about halfway through my fellowship. It's a 1-year fellowship.
Okay, 1-year sports medicine fellowship. And we can talk about that transition in a minute, but you're a physician. And that's not something that everybody has experience with. And unless they're sick, they go see one. So how did you get to where you are? Is it something, have you always wanted to be a doctor?
Yes, I grew up, my father was an orthopedic surgeon, and we lived in a small town in Wisconsin, and I just saw what an impact he had with the community. And even going through the grocery stores, and he knew everybody, patients would come up to him, and I saw what a difference he made in that community, and he was really kind of my role model. So I was one of those people who knew from elementary school that they wanted to be a physician. Yeah,
well, and I don't know if I've discussed this with any other guests, but I've had to have work done by an orthopedic surgeon, and the joke is kind of that they're, maybe 3 parts carpenter, 1 part surgeon, or 1 part physician kind of thing. But that also really depends on what patient populations you're working with. And so with him, were you in a smaller town or a larger town? Did he get to work with sports related injuries and reverse shoulder replacements for old ladies or whatever the case may be?
So, yes, he was a general orthopedic surgeon. So he was, one of a few in our small town. So he really took care of, a wide range of ages, a wide range of conditions.
Oh, that's awesome.
Yeah.
All right. So your dad was a doctor. What did your mom do, just out of curiosity?
So she was a teacher,
okay,
and then she was a stay-at-home mom. So she raised us.
Oh, nice.
Yeah.
Nice.
It was great.
All right. So right from the get-go, you saw his influence. You wanted to be a doctor.
Mm-hmm.
Where did you go to school?
I went to undergrad at Valparaiso University in Indiana, and then I went to medical school at the Medical College of Wisconsin.
Medical College of Wisconsin. And how did you end up all the way down here for this fellowship?
So I loved growing up in the Midwest. I think it's, a great culture, a great group of people. They have great values, but I wanted to experience something different. and wanted to get outside of the Midwest. So I matched to Virginia Tech Carilion for emergency medicine residency, and then really fell in love with kind of, the sports medicine side of emergency medicine, and, found that the University of Florida had a really great program for emergency medicine trained physicians.
Okay. Yeah, I don't know it makes sense, if you're thinking about with sports medicine, particularly if you're hands-on in practicing competitions, that it's acute response, or at least a portion of it is. And I'd like to talk about that in a minute. But I guess looking back and deconstructing it, it makes sense that transition from emergency medicine, trauma, stuff like that, to sports medicine. But I don't know if a lot of people would make that connection. Is that something that you specifically wanted to do? Did you have that in mind early on?
So I always had an interest in sports medicine. I grew up playing volleyball. I played collegiate volleyball at Valparaiso. So that patient population was always a passion of mine. And finding out, that I could be a sports physician from emergency medicine and really combine those things was really something great, because something that people might not realize is you still have to go through residency. So you still have to love what you're doing for a few years. And I still love emergency medicine. I still want to practice emergency medicine, but it would be really hard for me to do another specialty just to get to sports medicine.
Yeah. How long is the residency for emergency medicine?
So my program was 3 years. Most of them are 3 years. A few of them are 4 in the country.
Okay. So 3 and then an additional year
Yes.
to kind of focus even further and apply that to sports medicine. You're doing both at the same time now? You're practicing in emergency medicine while doing this fellowship?
Yes, it's part of the it's ACGME, which is just basically the governing body of residencies and fellowships. They require that you still practice 1 day a week in your primary specialty. So my co-fellow trained in family medicine, so he does a family medicine clinic 1 day a week, and then I do one emergency department shift 1 day a week.
Okay. Is it tough to juggle that with all of the? I mean, how many sports do you work at one time? I mean, there are times throughout the year where there are obviously multiple sports going on. Do you have multiple sports throughout the year and you're just working on one at a time, or do they overlap?
So the purpose of the fellowship is really to give us exposure to all of the sports. So we're covering all of the games, and then we do training rooms that involve all of the sports. And then during the day, we're doing sports clinics, and we can see, athletes or people in the community, your weekend warriors, kind of a broad range of things. But it's really nice to kind of be able to see, athletes all year round. And, people might not be familiar that just because your season ends, if you're a fall sport and your season ends in November, you're still working out, training,
Right.
practicing all year long. So things come up.
So you're all sports all the time,
Yeah.
plus that 1 weekly shift in the ED.
Yes.
How long is the shift in the ED?
Here it's 8 hours.
Oh, that's cakewalk, right? Just 8 hours of crazy and then you get to go.
It's great. I'm always revved up.
Yeah, so what's that like? Walk us through a typical shift. I get to hear this all the time because my girlfriend is now recently out of her residency in internal medicine and working as a hospitalist. So I get to hear about, all the trials and tribulations and highs and lows of her shifts. But she's not an emergency physician, and that's different. It's a different pace. It's a different environment. Tell me a little bit about, when you walk in the door to the time you're checking out and leaving.
Yeah, I think one of the things that I really loved about emergency medicine that drew me to it is your day is never the same. Every shift you go into, you don't know who's going to walk through the door, what's going to happen. There's some shifts that I walk in and I get a page and, there's a cardiac arrest coming in and you have 2 minutes. And you go to the resuscitation bay and you get your stuff together and you just go. And that rush of, just everybody working together and those critically ill patients is really something special that I like. But COVID, of course, has kind of changed the mix of it. But pre-COVID, it was a big diverse patient population.
So most days on those shifts, is it just one right after the other with patients?
Yes, especially working at a large academic level 1 trauma center. We have a lot of transfers come in because some hospitals don't have every specialty. So you're managing, transfer patients as well as the surrounding community, which I definitely can feel for the, lone emergency physician out there, and you need a super specialized person that's 3 hours away.
Right.
My heart goes out to them.
Just hearing that stresses me out because it seems like the exact opposite of what I get to do. If I'm interested in writing a paper looking at the effects of X on Y, and I haven't done anything with that, say in the past 3 years, it was part of my training, but maybe I haven't done anything recently, I can take all the time I need to look at the current literature, look at maybe recent discoveries to, get a refresher. It sounds like with you get a 2-minute heads up, somebody's coming in and, the stuff has hit the fan with that individual. And it's not like you have time, to break out your Grey's Anatomy or whatever and look through and this is what I need to do and these are the diagnostic criteria and blah, blah, blah. You have to have all of that pretty much ready all the time.
Yeah, I think another thing to kind of emphasize with emergency medicine is that, the training is really for resuscitation to manage those acute situations in the resuscitation and, ruling out life-threatening conditions. So a lot of things, even, chronic pain such as, chronic abdominal pain or things like that, part of our training is to make sure that you don't have a life-threatening thing. You don't have a bowel perforation. You don't have something that you are going to go into septic shock over in the next, day or two.
Right.
But once we rule all those things out, then we can kind of sit down back at the drawing board and think about, okay, what is causing these symptoms or what specialist can I get you to that can help figure that out?
Once you get them stabilized and sorted out.
Yeah.
Throughout that process, though, it seems like, just on a extremely layman's perspective, one of the normal doctor questions is, where does it hurt? Right? So to bring this back a little bit to pain, even if it's more acute pain, and we can maybe progress in looking at how to differentiate between symptoms that are a result of something that's been ongoing in chronic pain and acute pain that's because of whatever brought them to the ED. How big of a role does that play, and how do you go through that? And does that happen first, or do you have to deal with other vitals? Or
I think that that's a huge part, especially in the emergency department. My old program director in training, that was, one of his questions that he would always ask everybody, especially people with chronic pain. He would say, this has been going on for months, but what specifically brought you in today? What was different about today? And most people will say, well, there actually was an acute change or there was something different. Occasionally you'll get somebody that, well, this is the most convenient for me, and we're always happy to see those people as well.
Right,
but yeah, if really drilling down, okay, this has been going on, but what brought you in today?
Do you get a lot of people who, because you said two very different things within that comment, those who, have a change to their pain. So maybe something that's existing and it say, okay, well, my belly hurts over on this side. And it kind of always does, but now it hurts more. Well, that's one thing, but what about, well, my belly usually hurts on this side, but now it really hurts over here. Do you get both of those things? And what are, walk us through some of the scenarios that you have to, I'm sorry to do this, but I'm a huge fan. You kind of have to go through, a differential diagnosis and play Dr. House a little bit. Not play it because you do it for real, but you get what I'm saying. And work through some of those things. What are some of the challenges to that?
Yeah, I think, like you had mentioned, some people say, oh, I have always, pain on this side, but now it hurts over here. And, it's very common for people to kind of try to connect things temporally or, in a timely manner or, oh, I ate this for lunch and now, 5 hours later, my abdomen hurts or something like that. But all of those pieces might not be related. It's like true, but unrelated. It's
like all of the research. This is some Psych 101 stuff. And if I butcher this, it was a long time ago for me. But some of the work, if I'm remembering this correctly, some of the work that led to the research in superstition and ritual and stuff like that comes from observations of pigeons. And pigeons that were, I don't know if I can't recall if the studies. Again, I know I'm going to get comments about this from our audience, but I want to say that the pigeons were being used to study reinforcement. Can you teach a pigeon to click a button and get some food as a result of clicking that button? But there are different schedules of reinforcement. You can have it to where every time the pigeon clicks the button, they get food. Well, that's good, but if you're used to clicking the button and food comes out every time, and maybe you click the button 2 or 3 times in a row, you're going to give up if no food comes out. So that doesn't really condition them to click the button so well. So you can randomize it to where sometimes the food comes out, sometimes it doesn't. Well, if I'm remembering correctly with these studies, they would come in and observe these pigeons in really weird positions. some would have their wing out to the side, or standing on one foot, or in a weird posture, or you're making a weird sound, or in a weird part of the cage, whatever the case may be, because they were making that temporal connection that you're talking about. Well, this is what I did the last time I got food, so this must be what caused the food to come out. And they're totally wrong. and hence, sorry to ruin this for all the athletes listening, but like your lucky socks. So these are the socks that I was wearing when I won the state championship or whatever, or pitched the last no-hitter. So in this age where people have that to deal with, and they want to, and I'm sure they're just trying to be helpful. Hey, I did this, and this is what led to it. But then you also have WebMD, right? And so how much does that muddy the water diagnostically, not just with pain, but with anything, for your job of people trying to connect the dots and make it easier for you, but really, maybe throwing out red herrings and whatnot?
Yeah, I think definitely in, the time of the internet and all of these things where people can look things up, I can definitely sympathize with them, especially, you don't have a medical background and you think you have these symptoms, and then something crazy comes in, and then, that's kind of a great opportunity for patient education for us to go, okay, your entire, labs, your imaging, everything was normal, and this is why I don't think it's this, and this, and kind of differentiating that, but then kind of talking about another aspect of pain, I think, any elderly person with chest pain, I mean, that's terrifying in itself. And then, you get the 90-year-old that is like, well, I don't think it was a big deal. And they come in and it's, they're having a huge MI or, a heart attack.
I shouldn't laugh about that, but
yeah. And you're like, oh, why didn't you come in like a day sooner? And they're like, well, I always get chest pain.
Yeah, I always get gassy after I eat salads,
Yeah. So there's definitely, challenges to that.
Yeah. All right. So you went through your emergency residency. Mm-hmm. You transitioned into the current fellowship. What parts of what you're doing now with the sports medicine fellowship make you think, yep, I made the right choice in this one. This is what I'm doing? We'll talk about what comes next later, but just to reaffirm what you're doing now, what do you like most about your interactions in your job?
I really love combining emergency medicine with sports medicine. So anytime I get to use those acute emergency skills, that really makes the training feel like it was worth it, and that journey and those long hours. So that's really exciting.
Saving lives in the ED is not enough to reaffirm that. You have to bring it into sports too, right?
Yeah, it's really fun to combine the two. But I would say, the sports medicine population, getting back to, why I am so passionate about them, is because they're a very motivated population of people, and they'll say, I will happily try all of these different things if it can get me back to my hobby, my sport, my activity, or even just daily activities, and just kind of seeing them progress. And then something that I really like in sports medicine clinic is seeing these patients back week after week, which not all the time happens in emergency medicine.
And is this because they require continuing care to get back?
Yes.
Okay.
Yeah, to see, did that therapy or medication help? And then when it does, that's very rewarding to see.
Okay. That made me think of a little bit of a tangent. My entire show is tangents, by the way. So if you notice, I don't have a script in front of me here. When you're working with athletes, and I would imagine this happens also in the ED, maybe, I don't know how rushed you are and how much time you have in that. So I don't want to assume. But when you're working with athletes, at least, do you ever find that they're a little bit deceptive about how much pain they're in or symptoms they're feeling because they want to get back to competing, or are they pretty upfront with you?
I think, there's always that, you want to really relate to the patient and see, how much pain are you having, or, and things like that. But I think your physical exam skills and your history can really guide you, and imaging as well, making sure that they can return to sport as safely as possible.
And so some of those things are what you're saying were carryovers from your emergency training. Are there specific skills that you said you like to apply that to sports? Are there specific things that you can or do regularly draw upon that you can detail for us now? Like what exactly from your acute care and emergency translates over to sports?
I think one of the biggest things is ultrasound. In the emergency department, we use ultrasound for a whole variety of complaints between, heart, lungs, abdomen, musculoskeletal, and then sports. We have a huge emphasis on musculoskeletal, but then bringing in that emergency background, if somebody gets hit in their abdomen or has chest pain, I can put the ultrasound probe on and see, how's their heart functioning now? Is their abdomen looking okay? And just kind of blending those two things.
That's really cool. I wanted to very badly I found out some people who actually were able to stay awake for their procedure. I guess they did some kind of like spinal nerve block or something. But I at least wanted pictures or video of the inside of my knee when they were reconstructing my quad tendon. And I was denied that. They're like, yeah, we don't do that here. But that always fascinates me, the ability and the importance to not have to look at indirect relationships between signs and symptoms you can see externally and what's going on the inside. So ultrasound, allows you to look inside a person, but you can't see pain, right? Like you can't use an ultrasound to see pain. Right. You might be able to see something that could likely be related to the pain they're reporting. So it kind of sounds like it becomes a bit of a puzzle where you're putting those pieces together to get the whole picture.
Yeah, absolutely. And pain, is I think one of the things in sports medicine is to see, okay, what is the root cause of their pain? Because if it's something traumatic, and we're on the sidelines, we can obviously see that and there's a direct correlation. But, somebody that comes into clinic and they're having, foot pain, ankle pain, things like that, and there is no trauma, is it that they're, there's something wrong with their arch or how they're running and they need to do a gait analysis or things like that. With physical therapy, they can kind of really drill down and do more of a sports performance analysis to see, okay, what's the root cause of your pain while we're treating your pain at the same time, but how can we fix it so it doesn't get to a worse problem or it's not persistent?
Right. Just, treating the pain itself doesn't necessarily mean that's going to solve the problem long term. Maybe this is Hollywood. Again, I'm showing my ignorance of this, but can you alleviate pain to get a better idea of the cause of pain? Like if I, it's kind of, I think back to, cadaver anatomy when I took clinical anatomy. There's a lot of musculature in the forearm, right? There are multiple layers and all that. And some of those muscles, matter of fact, most of them manipulate the hand. And so if you're ever unsure, and sorry if I'm grossing anybody out that's listening or watching along, but if you're ever unsure, man, is this the palmaris longus? Oh, you're not really sure. Well, you know what you do? You tug on it and see what the cadaver's hand does as far as an action, in response to that muscle shortening. In the same way, can you, when you're treating someone, say, okay, well, we think the pain might be indicative of this trauma. So if we would do whatever, not centrally, not with something that's this systemic, like an NSAID, or obviously you probably don't use those in acute sense, but something like that. Can you specifically treat the pain to get a clearer image of what might be causing the pain? Or is that a little bit too Hollywood?
So I think in terms of like a clinic visit or in the acute setting, if we're able to reproduce the pain and not necessarily mask the pain, that is more helpful. And even, if somebody is hurting all over, whether it be in the emergency department or in the sports clinic, if you can, push on somebody's knee in that spot or, kind of do a physical exam scale and say, is that the pain that you're experiencing that brought you in today? Is that the thing? That is more helpful to us.
Do you get a lot of cases where, maybe somebody has multi-site or widespread pain, but then there's also something that is an acute pain-related trauma. And the reason why I ask this is there's a fair amount of research that again, some of my mentors and colleagues that are working on in multi-site pain or widespread pain. But one thing that we see is if we circle back to, and this could apply to younger populations as well, but with older populations, people who have chronic pain, particularly long-term chronic pain, they can and often do develop alterations in their pain sensitivity. That central nervous system built-in effect to modulate pain gets out of whack. And so other things will hurt more, or things that wouldn't normally hurt. You get like hyperalgesia, right? Something that wouldn't normally hurt all of a sudden does. That seems like that could really make figuring some of those things out difficult. Do you see that very often with younger people or in the ED in general?
I think what we see more commonly is, somebody comes in and they will say have chronic right knee pain. So then they adjust how they're doing activities or how they're walking, and now suddenly some part of their left
My
leg
left hip hurts. Yeah.
Yes.
Right.
So we're seeing kind of those compensatory mechanisms.
Mm-hmm.
And I think in fellowship, what we're really learning is, all of the biokinetic chains and how everything is really so intertwined and so interconnected. And if one thing is off, that can cause kind of, this trickle down effect and have a lot of things.
Yeah. That's fascinating to me. Just with my background in sports and in coaching and some of the things that I have to do in training, or used to have to do in training, to help, strengthen and improve, joint balance and do the things that make athletes more bulletproof to resistance, or to injury rather, make them more injury resistant. Learning some of those connections. It's almost like, making a trick shot in pool, right? If you're making a combo, well, you're shooting a ball straight in. That's, you can figure out some angles and stuff. But if there are two, then a small change in how you hit the first ball can have a huge effect on where the second ball goes. And that's why you don't shoot it like, make 3-ball combinations and stuff, because very small changes in that chain, and go figure, that's kinetics also. But that can result in really huge differences and have sometimes opposite effects. And you mentioned, my right leg hurts, and so I've been limping or favoring it or changing my movements, and now all of a sudden I'm having low back pain on my left side or something like that. Does that happen a lot?
Yeah, it does, and that really kind of plays a role into how big physical therapy is too, because even a lot of these chronic injuries or chronic pain that somebody comes in for initially, the physical therapist can kind of go through and say, okay, well, we need to strengthen up this muscle group, so then it not only fixes the primary problem, but now it also fixes all the other downstream effects.
Yeah, so there's over time. Well, and I guess that's regardless of what age or condition or reason you see the doctor, that sounds like a really good reason to see the doctor sooner than later, right? Because if you don't go, then you can get all of these compound effects that come from the original injury that you didn't look into and get fixed. And then I would assume that treatment recovery takes even longer.
Yeah, definitely. And even that plays a role in the whole sports performance world, where cyclists will come in and do a bike fitting, and because they're having some knee pain, but that cartilage on their kneecap is constantly rubbing if they're a professional cyclist or something like that. And how can we adjust the seat so that cartilage isn't hitting in that spot anymore? Otherwise, if you keep doing it, it's only going to get worse.
Right. Now, do you find that, and I guess this comes back because you gave two starkly different examples when you talked about where you have to put in the most time with sports. One seems to be very acute type injuries where very large guys are crashing into each other pretty regularly on purpose. Then the other side, and not to say that there aren't large cross-country athletes, but those people are built very differently than football players, most football players. But the difference there is the repetitive type thing. And speaking musculoskeletal-wise, I know that you said a lot of the things that you treat are more environmental stress and heat stroke and stuff like that. But what do you see more of from a musculoskeletal standpoint? Do you see overuse type injury or what do you get exposed to the most? Not in the ED, but with from the sports medicine side.
Yeah, I think definitely endurance athletes, their host of injuries are more overuse, chronic, and those people, even marathon runners, how can we look at your gait and see, are you a 4-foot runner, are you a heel strike runner? Those, how can we adjust to not have as many overuse injuries?
And the reason why I asked that is a little bit because we try to do with this podcast, we try to accomplish a few goals, and one is try to have fun and try to inform people and people that are science nerds and whatnot, but also a little bit of education. And the reason why I asked that question is more often than not, when it comes to chronic pain populations, we've already addressed the first thing. Something happens, you don't see a physician and address it, then it becomes even bigger problem than it should. But the other thing is the big difference. You can have all of this force of a couple people colliding or some 350-pound guy running into the side of your knee, and those things are bad. But with cross country, you're getting something or cycling, getting something that's very innocuous, a light movement, a running step. And it's, I don't want to say gentler, but it's just not as intense as the other thing, but you do it hundreds or thousands of tens or thousands of times, much like walking or doing activities of daily living if you're older, going up and down stairs. And so how you pay attention to and modify those movements seems to be really important in athletics. And would it be safe to say that it's probably the same for even just people in their everyday lives, how you sit at your desk, how you get into your car, et cetera?
Yeah, definitely. And I think what's different with elite athletes or even being on those athletic teams of endurance sports is you are going to have at least one coach, if not multiple coaches, helping kind of, the training program and the cross-training program. But if you are a person who wants to take up running as a hobby and you're by yourself and, you go from zero running to now you're running 10 miles a day and that's all you're doing, that's where you see the injuries, and really putting an emphasis on strength training to strengthen up those leg muscles. So you're not, you're helping kind of alleviate the impact of the running.
Yeah, that's brilliant. All right, so what comes next for you? We've gotten you up to where you are now and what you're doing now.
Yes.
You're halfway through this.
Yes.
So in another 6 months or so, fall of this coming year. So that means you won't be around for another volleyball season?
We'll see. I'm still TBD on my plans for next year, but I'm hoping that I can combine emergency medicine and sports medicine.
Okay. Would you, if you had your druthers, would you stay here in Gainesville to do that, or would you like to try something new?
I've loved my time in Gainesville. It's my first time living in Florida and can't complain about the weather. The people are great. I think it also helps that it's so sunny here. People are just happy.
Maybe that might help people be happy. I'm a Michigander, and so I don't know. It's funny because you say you come down here and you dealt with plenty of cold and snow and all that, Wisconsin. I didn't have to live in it for as long up north, but when we have too long a spell of hot, humid weather, that doesn't do well with me. Like the last few days here, it's been kind of cold and drizzly and whatnot. Not so much today. Today's really nice out, but those days, scattered in, I like a little bit more. But I feel you. You like the weather and stuff like that, and the people. What if you do? Well, obviously you're going to stay on and combine emergency medicine and sports medicine, but what's your ideal way to do that? Would you want to stay at a university and work with college teams, or would you like to be very specific and work with a single sport and a single professional team year round? Or?
I think combining it, meaning still doing emergency department shifts and then still doing sports medicine clinic days within the community, and then covering sideline sports in whatever capacity that may be, but just kind of having a mix of different things. And I think that's a common thread with people who go into emergency medicine as it is nobody wants the same thing every day.
Right.
So, by the end of it, everybody has, 10 different jobs.
So the stuff that stresses me out about having to switch with all these teams is actually what draws you to this job.
Yeah.
That's good. That's how you know you're in the right spot, right? With regard to both emergency medicine and sports medicine, with all of what you do as a physician, what are some of the new and exciting, whether it be techniques or, I assume that you have to remain pretty evidence-based in your job, right? So how often do you have to circle back and look at new literature and new research to refine your practices? Let's start with that.
I would say it's constant. Even through residency and fellowship, we're learning about all of the new and exciting things. But then even after my training, it's just, there's always science, there's always research coming out, and that really drives practice changing. The way that we practiced emergency medicine 10 years ago is totally different than today, which is exciting and is really driving, improved patient care, improved outcomes.
Is there something that just first thing that comes to mind that's relatively recent that when you learned this or implemented it or saw how effective it was, you went, oh, that's cool. I'm glad we figured that out. Is there anything new in that respect that you can think of?
I would say getting back to ultrasound, the technology of starting to use ultrasound and to apply it, especially in the capacity that emergency medicine can. You can take the same ultrasound and diagnose somebody with a retinal detachment in their eye and then go to the next room and see, are they in heart failure? Are they having a heart attack? And then go to the next room and say, okay, what does your knee look like? And just that is so dynamic.
Really
and
diverse tool.
Really practice changing.
Yeah. How much training does it take to get proficient with that? Because I would imagine with ultrasound, I have a little bit of experience here, but there has to be not even looking at interpreting the images, but just settings. If you're looking at different depths of structures within the body, and maybe different densities of tissues, you have to set the machine differently in order to do that, right? And then you have to interpret the images that you're seeing. How much training does all that stuff take?
So it's really become a fundamental core part of emergency medicine, where we are starting to get trained from day one of intern year, and you're using it every single day, and you're having dedicated ultrasound sessions. So it's really been a fundamental part.
That's cool. All right, so you want to stay doing what you're doing. You want to have a little bit of everything, which that's the best thing that college towns provide, of course. Like you can, if you want to have, my job, I get to write, I get to do podcast stuff, I get to broadcast for sports. Not a whole lot of places other than I guess maybe a big metropolitan city. But so if and when you stay here and you apply this, is there something that you specifically want to work on and develop and get either make more central to your job, or just something that you already do and get better at as you move on?
I would say, there's definitely a couple of different things that I want to develop through my practice and through my career, but something that I'm particularly passionate about is incorporating sports medicine and everything I've learned in fellowship, because in a sense, it's a whole nother specialty that I've done this past year, and bringing it back into emergency medicine and educating the residents, because in my residency, I was one of the few residents who was excited about their orthopedic surgery rotation and doing all those procedures. So then even on my emergency department shifts, everything I learned, this past week, I'll take into the shift and teach the intern. And I love kind of incorporating that education model.
That's awesome. And then last question before I let you go. Is there anything, because we get to look across the table, and you're a practicing physician, so you're on the clinical side of things. I'm on the research side of things. Whether it's applied physiology and kinesiology, which is kind of core to my training, not kind of, it is, or pain, is there anything that you're really thinking, man, I hope they unlock this. I hope that we figure this out soon, because it would make my job a lot easier? Is there anything you can think of there? I know that's a put you on the spot, but
yeah. Oh, that's such a good question. Man.
Because that's some of the things that we look for, right? We want to know, from the research side, because we have to be somewhat reactive, but also somewhat proactive in the questions that we ask to design our studies and to direct our focus and our work to be most beneficial, at least for me, in a clinical setting. I don't want to do something that I might be able to get published and somebody's going to go, oh, that's really cool. And then it's 15 or 20 years and somebody's digging through, papers that have never been cited, but maybe 3 or 4 times, go, oh yeah, that Crow guy, he's found this. I wonder if, I want something that in 5 years' time, a physical therapist or a gerontologist or a sports medicine physician, or even in emergency medicine, then go, okay, so all of the work that's being done here, I think we can apply this and do something that we weren't able to do before, either diagnostically or in treatment. But we look for those things. We want to try to find those gaps in knowledge and those areas where if we could just plug a piece or two in, it would really go a long way to make your job easier. Can you think of anything that it's like, this is a repeated problem, and we have to do so much more just because we don't know how to come at it from this angle? Or
I think from the emergency...
Did I talk long enough to let you think about it?
I think from the emergency medicine standpoint, with specifically like the opioid epidemic that we've seen, and now, in Virginia, that was a huge problem, and we had a large Suboxone clinic, and putting patients from the emergency department, starting them on Suboxone to their treatment course, which I think was a great program. And
sorry to interrupt. Catch people up on Suboxone. So for anybody that's listening that's not familiar.
So people who have had an addiction to specifically opioids, Suboxone is a medication that can help bridge that addiction, so you're not going through withdrawals with withdrawal symptoms being, very uncomfortable. And I mean, my heart goes out to those people when you see them in acute withdrawal, because they do really feel like they're dying. So it helps kind of ease that while they are on their treatment pathway. But then what we see is, somebody comes in who has had a history of opioid addiction, who is now on Suboxone, and then they come in with a real pain problem, meaning they come in and they have acute appendicitis, or they come in from a trauma and, they broke their leg or something, and you do want to treat their pain, because their pain in that moment is very real. But then finding different ways to do that. So now, ketamine is the hot topic. And just different ways to do that. But it can be a struggle when you're trying to throw this multimodal pain management situation and, when opioids would be the typical, severe pain control that we would use, but we can no longer use them. I think that's kind of...
We've really dug ourselves into a bit of a hole there with the opioid use and whatnot. Yeah. Well, thank you so much for coming on and spending time. I was really excited to talk to you, to diversify our content a little bit more. And I know we didn't dive really deep into, pain research or pain treatment specifically, but I thought this was a really good opportunity to learn a little bit more, even if that's just one piece of what you do, about emergency medicine and about sports medicine. And I think you've done a really good job of painting that picture. So thank you.
Thanks for having me.
Thank you for joining this episode of The Price of Pain. Opinions expressed on this podcast are solely those of the host and guests, and not representative of the University of Florida or parent institutions of our guests, unless specifically stated. You can find more information about Price on the World Wide Web at price.ctsi.ufl.edu. And keep up with our researchers on social media by searching Facebook for UF Price, by following @UF_pain on Twitter, and Price of Pain Podcast, all one word, on Instagram.